Hello everyone, I'm Shihan Zhang from Southeastern University. Today I will be presenting our research on SARS-CoV-2 humoral immunity profiles in community populations of Eastern China, a longitudinal study. I'm going to walk you through these four main aspects. Now let me give you a brief overview of the background of our study. As we know, the COVID-19 pandemic has persisted for over 4 years without showing signs of abating. Recent reports from various countries indicate an increase in severe cases and fatalities. In response, vaccines were rapidly developed at an unprecedented pace, saving millions of lives. However, the continuous emergence of new variants and the waning immunity over time have diminished the effectiveness of vaccines against the symptomatic disease, leading to an increasing number of breakthrough infections. Additionally, with widespread exposure to both vaccines and natural infections, many individuals have developed what's known as hybrid immunity, adding complexity to the overall immune landscape. Serum monitoring provides key insights into SARS-CoV-2 infection patterns and tracks population immunity after vaccination. Binding antibody levels correlate with the neutralizing capacity, though this varies with time and the immunoassay used. To accurately measure these antibody levels, we use the high-throughput immunoassays. These assays include competitive inhibition methods like enzyme-linked immunosorbent assays and chemiluminescence immunoassays, which are well-established tools for detecting binding antibodies. Additionally, we employed microneutralization tests and pseudovirus neutralization assays to measure neutralizing antibodies, which are essential for assessing protective immunity against the virus. By utilizing simple, standardized, and widely employed immunoassays, numerous studies worldwide have investigated serum binding antibody levels in populations, including IgG. Deborah find that IgG antibodies against SARS-CoV-2 rapidly peak 3 to 5 weeks after infection, followed by a swift decline during the early convalescent phase. Chen et al. Monitored BBIBP vaccine-induced virus-specific antibody levels over multiple time points and showed that serum antibody levels decreased over time. And prior infection enhances the immunogenicity of primary SARS-CoV-2 vaccination, resulting in a humoral response amplitude comparable to that of 2 doses of mRNA vaccine in infection-naive individuals. Several studies have also explored factors influencing IgG antibody levels, such as sex, age, vaccine doses, and reinfection. Although the existing studies have examined the temporal dynamics of serum binding antibody levels and their influencing factors, most of these studies are based on populations with relatively homogeneous immune backgrounds or focus on specific groups, such as healthcare workers, who are easier to track over time. Additionally, few studies have provided the comprehensive antibody dynamics curves throughout the observation period. So in this study, we addressed these gaps by conducting a community-based follow-up of SARS-CoV-2 specific IgG antibodies in Jiangsu province, an eastern region of China. The follow-up spanned 6 months, beginning in December 2022, with each round of follow-up occurring every 2 months and covering over 10,000 participants. This period coincided with a nationwide wave of Omicron BA.5 sublineage infections, making our findings particularly valuable for understanding the real-world immune barriers in a population with hybrid immunity following large-scale infections. Figure 1 shows the timeline of the 3 follow-up visits and the participant enrollment follow. In total, 2,737 participants were continuously enrolled, and their IgG antibody levels were collected. The method used in this study was chemiluminescence immunoassay, performed on an automated magnetic chemiluminescence analyzer. The signal was measured as a relative light unit, RLU, using the optical system of the analyzer. The titers of AC to competitive antibodies in the serum sample were measured as a sample cutoff by comparing the RLU of a sample to the cutoff determined from standard curves. While a definitive protective threshold for IgG has not yet been established, we adopt a reference from existing literature to set the threshold in this study. Participants with antibody levels below this threshold were considered susceptible, namely seronegative, while those above were classified as protected, namely seropositive. Seroconversion was defined as a shift from seronegativity to seropositivity, and the seroreversion referred to the loss of protective antibody levels over time. We performed several statistical analyses in this study. First, we conducted a descriptive analysis of participants' baseline characteristics with log-transformed IgG antibody levels following a normal distribution. A generalized linear mixed effects normal was used to evaluate factors influencing IgG concentrations. We also applied KM survival analysis to estimate the cumulative incidence of seroreversion, and used generalized additive mixed models to capture nonlinear trends in IgG levels over time. Here are the main findings of our study. Table 1 presents the baseline characteristics of participants along with the IgG seropositivity rates and quantitative IgG levels across 3 follow-up visits. Table 2 shows the results of univariate and multivariate regression analysis using GOAM to identify factors influencing IgG antibody levels. Significant factors include age, vaccination status, and infection history, with older age, full immunization, and multiple infections being associated with higher IgG levels. Table 3 highlights the effect of different booster methods and types on IgG levels. Inhalation boosters and adenovirus vector vaccines were associated with significantly higher IgG levels compared to intramuscular injections and inactivated vaccines. To further explore IgG antibody dynamics, we used the GAMM to capture non-linear trends. Figure 2A shows that IgG levels initially rise, peaking around 44 days, then decline before a modest increase later. Throughout this study, antibody levels remain above the protective threshold. Figure 2B illustrates that individuals aged 65 and above had lower IgG levels and a faster decline rate compared to younger groups. Figure 2C and 2D highlight that booster doses helped maintain higher IgG levels, while those unvaccinated or partially immunized had consistently lower levels. For infection history, individuals with 2 or more injections showed a slower decline rate than those with just 1 infection. In the cumulative incidence analysis of seroreversion, we included 2,133 participants, excluding those who remained seronegative throughout. Figure 3A shows that participants over 65 experienced earlier seroreversion, but later stages showed higher rates among those under 18, likely due to more stable antibody levels in younger individuals. In Figure 3b, unvaccinated or partially immunized participants had the highest seroreversion rates, while those with booster doses had the lowest, with about 60% reduction. Figure 3c highlights that those with no prior infection had the highest seroreversion rates, while those with 2 or more infections had the lowest. Finally, we focused on participants over 65, where booster recipients experienced a 40% reduction in seroreversion, suggesting a protective effect for the elderly. Finally, to summarize the entire study. In this study, we aim to characterize the real-world population level IgG antibody levels in Jiangsu Province, China, following the large-scale infections caused by the Omicron SARS-CoV-2 variant between December 2022 and January 2023. Additionally, we analyzed the factors influencing IgG antibody levels and the temporal changes in cumulative seroreversion rates across different population groups, with the goal of optimizing future individualized vaccination strategies. Our investigation reveals that after the Omicron BA.5 wave at the end of 2022, the seroprevalence in the population exceeded 85%. We observed several factors influencing IgG antibody levels, including age, vaccination regimen, method of administration, and previous infection history. Our findings showed that IgG levels peaked approximately 1 to 1.5 months after infection, and by around 3 months, antibody levels had declined to a low point, yet remained above the protective threshold. Another significant highlight of this study is the characterization of the cumulative seroreversion rates over time across different population groups. A few limitations should be highlighted. The protective threshold in our study was determined based on an observational study, which may involve some uncontrollable confounding factors. The GAM model smoothed observations over the follow-up period, potentially overlooking individual antibody titer trajectories. During the third follow-up after the large-scale infection, some participants experienced reinfection. However, we did not conduct lab tests to identify viral variants, potentially missing variable data. The follow-up period and the number of rounds could be extended, and incorporating additional serological and cellular immunity markers would offer a more comprehensive assessment of population immunity dynamics. For the successful completion of this study, I'd like to acknowledge the hard work and the dedication of our team members from Jiangsu Provincial Center for Disease Control and Prevention and Southeast University, China. Thank you for your attention and participation.